You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. We are your hosts. I am Kelly Holmes, and my preferred pronouns are she, her.
I'm Lerenza Howard, and my preferred pronouns are also she, her. Hey, Kelly, how are you?
I'm good, Lorenza. How are you?
I'm doing well and very excited about today's episode.
Yes, I am too. Today we are broadening our perspective with some global infection prevention specialists, and I'm pleased to introduce Filippo Medioli. Born in Milan, Dr. Filippo Medioli is an infectious diseases specialist at Humanitas Research Hospital in Italy and a PhD candidate at the same institution. His expertise extends to antimicrobial stewardship and clinical infectious diseases, reflected in his role as an ad hoc member of the SGAP Executive Committee, which is the European Society of Clinical Microbiology and Infectious Diseases Study Group for Antimicrobial Stewardship. Dr. Medioli has broadened his international experience through a clinical observership at Hospital Universitario Virgen del Rocío in Seville, Spain, from May to July 2024. Additionally, he serves as the network officer for the Trainee Association of European Society of Clinical Microbiology and Infectious Diseases, or ESCMID, beginning in April of 2024, fostering collaboration among early career infectious disease specialists. And in his free time, he enjoys expressing his creativity through painting and drawing.
And later on, we will bring on Tatiana Izakovic to the conversation, who is an experienced CIC certified hospital epidemiologist and infection control specialist. She is currently a PhD candidate at Comenius University School of Medicine in Slovakia, where she also serves as an adjunct faculty member in the Department of Hygiene. Dr. Izakovic has held leadership roles in infection prevention and hospital epidemiology, including serving as a hospital epidemiologist at Hospital Bori and as an infection control consultant. She is an active member of international professional organizations, including, like Dr. Filippo, ESCMID and APIC, where she chairs the communication committee. Her research and presentations focus on hospital-associated infections, patient safety, and epidemiological strategies. Dr. Izakovic holds an MD from Comenius University and a master's in healthcare administration from the University of Iowa. Welcome to the show.
Let's jump right in, Filippo. So we're really curious, how do infection control strategies, differ between countries? You're located in Italy, Tatiana is located in Slovakia. Are there any specific challenges that you can address for your country?
Well, first thing first, I would like to thank you for having me. I think it's a great opportunity to share my experience and what's happening in Italy according to infection control. And I think that the biggest challenge that my country is currently facing, according to antimicrobial resistance really in general, is that we are doing too little too late. We are currently the second worst country in Europe for antimicrobial resistance after Greece, but we started only a few years ago to implement infection control and prevention strategies, and especially implementing antimicrobial stewardship. So it's something relatively new in our settings, and we should be doing more, way more than we actually doing. So I think we're running late. That's the main issue that I found in my setting. But luckily enough, it's plenty of young specialists like me. I have a lot of colleagues that are currently very aware of the situation and then want to do their best, even if the resources are scarce. The second main issue is that the resources are scarce, as our healthcare systems are 100% public, and we are facing understaffing and under representations really with stakeholders. So this is the second main problem, I think, in our setting.
Filippo, I had a question about when you note that, just for clarity for listeners, you noted that the healthcare is public. What exactly does that mean?
Thank you for the question. It means that everywhere in Italy, it doesn't matter whether you have an insurance or not, you are up for receiving every possible cure for any kind of disease everywhere, all paid by the state.
Mm-hmm. Okay. Thank you for clarifying that. And I can only imagine with being in that sense of, being more reactionary instead of proactive, that can present its challenges to the infection prevention professionals. But tell me, Filippo, what are some of the biggest obstacles healthcare professionals face in implementing these infection control policies, especially in with being a resource limited, nation?
I think that the biggest problem is convincing stakeholders and the direction that it is important to screen patients. So, for instance, being resource limited means that convincing people that we should actually invest money into doing screening. So, in microbiologically do the screening exams on patients, especially the immunocompromised one, the most fragile ones, is the first step and the most important thing that we face every day, because most of the time I tend to ask as an infectious disease specialist for I don't know, rectal swabs for patients that get into the emergency room, and the answer from the lab and from the direction is that we cannot afford that. You should just invent what's the actual colonization of the patient. So that's the main problem I face every day as an infectious disease specialist working in infection prevention and control programs.
Oh, wow. That is, a huge obstacle. Have you all looked at identifying high-risk groups only in that situation so that you can conserve your resources, or how do you go about tackling that battle?
That's precisely what we did. We identified risk groups of patients that should be screened promptly as they come into the hospital, such as the immunocompromised ones, like, for instance, stem cell transplantation recipients, or patients that undergo a chronic steroid therapy. We managed with evidence, basically showing literature, to convince our direction to when I say direction, I say the head of the hospital, which rarely is a doctor, to invest at least in buying the samples and the screening tests for the risk group patients. Universal screening is something utopic that I would wish to achieve one day, but in most of the hospitals, at least in Italy, it's non-achievable right now with the resources we have.
And what target multi-drug resistant organisms are you looking for in this screening process?
I look mostly for carbapenem producing Enterobacterialis or vancomycin resistant enterococci. Those two are the ones I'm looking for, especially in the immunocompromised patient. Okay. Instead, in the pre-surgical patient, I try to switch my focus more on MRSA nasal colonization in order to give a rightful prophylaxis for those patients once they go to the operation room.
Yes, our challenges with those MDROs are quite similar. So tell us a little bit about staffing for infection prevention in Italy. Do you have a particular person that's in charge of this function? Are they typically a doctor or a nurse? And is there any sort of formal training that these individuals go through?
Thank you for the question. Normally, historically, let's say, infection prevention and control strategies in Italy are something that are held by the hygiene and preventive medicine doctors that normally organize the programs, and the effective part of the strategies are made mostly by nurses. Only, let's say, starting 5 years ago, thanks to the SGAP really, and ESHMID and EUCIC, which is infection and prevention control part of the European Society, we started to understand the multifaceted roles within infection control programs. And so we started as infectious disease doctors to be a main core part of these programs, as historically we were not. So we started to enlarge the figures within it. But yes, normally it's the hygiene and prevention medicine that coordinate the nurses, and there is no peculiar path in university, at least, or either in specialty school. You become an infection prevention specialist via master. So you do a master in Italy to become a figure involved in such programs. And as I said, just lately, just in the last 5 years, we as infectious disease doctors became part of it.
What specific field must you obtain that master's in? What requirement? Is it any master's degree based on the educational framework?
You just need a health degree of any kind, as you can access to that master via nurses path, I mean, or either being a medical doctor. It really doesn't matter. You just need any health related degree, and you can access to that. It's normally 3 years long, and the main focus on that master is about dealing with the isolation. So you learn how to deal with a specific MDR and what kind of isolation they need. It goes without saying that, for instance, us as infectious disease specialists, also clinical microbiologists, already have this kind of instruments in their path. So it's quite I don't know how to explain it, but I think it's totally useless, this master, for most of us as doctors that already has this kind of formation.
Okay. So is there any formalized, is this equivocal or equivalent to like a public health degree, or are there separate degree programs for public health within Europe?
No, I'll try to explain it. If you want to become a public health doctor or be involved into public health, you just have to do medical degree and then the specialty school for hygiene and preventive medicine, which is something separate. It's 4 years, but you don't have to undergo a specific master or whatnot. Equally speaking, an infectious disease doctor does other 4 years after his or her medical degree to become infectious disease specialist. But in order to become an infection prevention and control specialist, you just need the master or either an equivalent specialty degree, which could be infectious diseases, hygiene and preventive medicine, or clinical microbiology. These three specialist degree could make you it's equivalent to having the master.
Gotcha. That's very interesting to learn, internationally, the requirements to enter into this profession. And of course, as noted, global health, just transitioning to a different topic, of course, global health is absolutely important. This is the premise of this conversation. And that global health is at the forefront of many of the dialogues and conversations that are occurring here within the States. I will share as it relates to, public health. And one of the components of global health that I think is important is cultural competence, in order to successfully implement initiatives. So share with me, in what ways do cultural perspectives and organizational policies shape approaches to infection prevention across, across Europe? And then secondly, are there any strategies or practices that could be effectively shared and implemented on a global scale?
Thank you very much for the question. I think that as an Italian doctor, I found solace within the European society, as they gave us, as a country, most of the evidence and the practices we're actually deploying in our settings. So most of the people, the specialists that I talked to, that are verging in the same situation, both with MR or IPC strategies implementation, we found a lot of solace and guidance into the European society, as they also gave us, in some specific moments, I remember a crab outbreak in ICU in my center. They sent some professor from a German university to give us guidance and to give us counseling. So I think that when we talk about European-wise, the European society really helped us a lot into that, both creating solid evidence and creating a good network within that. And I think that we're starting to see the problem from a global point of view as well, and we're trying to implement as a group, as a study group within the European society, programs that could be deployed also in other settings, especially low middle income countries, and creating new instruments for other people that also are verging or verged into the same problem. So I think the most important thing of all is network, really creating a good network. It's changing the game, I think.
Mm-hmm. So in that network, is ESHMIT the network that connects you all? What net? I know, in the States we have APIC and we have, SHE as some of the governing or professional organizations within our country. So is ESHMIT that connecting body?
Yeah, it's definitely ESHMIT. It's connecting us all, and it's really helpful.
So I noticed on LinkedIn recently that you're the winner of the Antimicrobial Stewardship Pilot Project. And then you also recently published a paper, right, on enhancing antimicrobial stewardship in clinical microbiology and infection. Will you tell us a little bit about those projects, and then, any innovative strategies that you are seeing some promise and, seeing the improvements being made?
Yes. Okay, the pilot project that you're mentioning, the one that I won an award for, is something that it's 1 year I'm working on, actually, because as I mentioned, one of the main problems within antimicrobial stewardship programs and IPC programs in my setting is resources, really. So trying to use wisely our resources, I think it's a core element of every antimicrobial stewardship program here in Italy. So I tried to develop a diagnostic stewardship programs for urine cultures, in order to make all the prescribers, or at least the diagnostic exam prescribers, due to give to the laboratory a quick review about the real indication for the execution of that exam. And whenever that information is not provided to the laboratory is entitled to not perform the exam.
Mm.
And this is like the aim is to reduce the inappropriate urine culture performing, and also to reduce indirectly the misuse of antibiotics, of course, for instance, asymptomatic bacteriurias, which is a plague in my setting. I got a lot of credit for that because actually it's a great problem all over Italy, and reducing the unnecessary exams, I think it's pivotal. According instead to the paper you mentioned, it's something that I made within SGAP, as they asked me to review the UNGA document. I don't know if you are aware of the United Nations document. They had an encounter later this November, November 2024. They discussed about antimicrobial resistance and all the efforts made so far and the efforts for the future. And they published a document about what came out of that meeting, and I read it thoroughly, and I decided with SGAP to write something that would underline, of course, the important parts of the document, but also the parts that are a little bit lacking in my opinion, in our opinion as SGAP, really. And the most important thing, I think, is that there was no trace, or at least there was scarce trace of the importance of formation in antimicrobial stewardship and infection control programs, as forming new people, giving the right instruments to everybody, as it is a global problem. It's right the center of it all. And that's the main issue I encountered in that document, but the rest it's other minor issues.
Well, it's wonderful. Congratulations on the project. It's very important work. Diagnostic stewardship is, a newer term, I think, that we're using in the United States as well, or we might call it culture stewardship, but really trying to explain, if we're doing unnecessary cultures, the patient is more likely to be exposed to unnecessary antibiotics. And then the same with blood culture contamination, and really trying to drill down on that, because when we get those, contaminants in our blood cultures, those patients always get the antimicrobials as well. Is that something that you have struggled with?
Yeah, definitely. But improving the blood culture, sorry for the pun, is a little bit trickier, and so I decided to start with the low hanging fruits, as most of the stewardship programs suggest to
Absolutely.
to do. But we're planning to expand also our program on the blood cultures. I must also admit that most of the inspiration, at least from the literature, I got it from USA experiences. So thank you guys for giving us so many good examples on diagnostic stewardship. I think in our setting that's the thing. We should aim to that.
Well, I think you make a very strong point in, resource limited areas, that you do have to decide what is our biggest risk. Because if you have too many goals, let's tackle it in every single way, you're going to spread yourself too thin. So by identifying that, let's start with diagnostic stewardship of urine cultures is, a very solid plan to move forward. I like it.
Yeah. Filippo, that's phenomenal. I know that, of course, in the States, there's areas of opportunity, as Kelly noted, related to, culturing stewardship, diagnostic stewardship. So I just want to be clear as it relates to your initiative. So, as it relates to your research, is the goal to ultimately implement this diagnostic stewardship program across Italy overall, or is it just based at one hospital institution?
Thank you for the question, Lerenza. No, I would like to implement it in my hospital because that's where I have the most effective connection with my head of department. And so I know that's going to work, at least in the first part. Let's see, the indicators will speak. But no, I cannot say I will implement it in the whole Italy yet, for sure.
Thank you. Thank you. And then let's bring Tatiana into the conversation. Tatiana, I'm curious to know your insights. Of course, the pandemic has shaped us and reshaped us within healthcare and just in our personal lives, and in going through this experience. But of course, in many areas globally, including in the States, we've experienced COVID fatigue. But I'm curious to know from your purview, how has the COVID-19 pandemic reshaped infection prevention protocols in healthcare settings across different countries?
Thank you, Lorenza, for the great question. So during majority of COVID-19 pandemic, I was here in the United States, but I returned to Slovakia in 2022 when I started to work as a hospital epidemiologist. And I have to say that COVID-19 has actually helped to bring more infection control and hospital epidemiology awareness among healthcare professionals in Slovakia, but also among general public, which I think is great. And I could definitely see that since COVID-19 pandemic, healthcare professionals in Slovakia started to wash their hands more frequently, which is great. And now the majority of these healthcare professionals, but also general public, understand the importance of having infection prevention control programs implemented at every healthcare facility, which was not always the case before pandemic. So we still do have much room for improvement in Slovakia, but I think this was a great start for us. The pandemic really helped to push it forward.
Oh, I love hearing that, Tatiana. How would you compare your experience, Tatiana, with COVID between the United States and Slovakia? Do you feel like it improved the same in both countries or different?
So here in the United States, we really have a well-structured infection control programs in majority of the hospitals, I would say, at least in the hospital where I used to work here in the United States. So we just enhanced all of the infection control practices because we already knew what works the best, and we just pushed a little harder and worked a little harder. In Slovakia, people start learning about infection control in hospital settings during the COVID-19 and starting reading about it more. So here in the United States, we already knew what to do and just push it more. And in Slovakia, we started exploring this area, if that makes sense.
Well, how does ESHMID? I know that you're involved in ESHMID. So if there is any anything that we can glean from the APIC resources, are there any areas of opportunity in there being that merger of some of the research best practice? Because I know with Filippo's research, he noted that there's been some information that he's researched and utilized within his research studies. Are there any areas of opportunity for there to be some use of the existing tools for infection prevention in Slovakia and abroad?
Yeah, well, there's a lot of international infection control resources out there that healthcare professionals in Slovakia are starting getting more familiar with these resources. So people start looking for these and started to learn more about what works the best within healthcare settings and how to best prevent healthcare-associated infections. It was less common before COVID-19, I would say.
Filippo, yeah, I'm interested. We read very scary stories from Italy during the beginning, especially of COVID. So same question to you. How do you feel like it has, changed infection prevention in Italy?
Thank you for the question. Well, I was right out of med school when the COVID started in Italy, so it was quite scary, and I think it jeopardized completely what was being done so far on infection prevention and control, and we were completely unprepared for that. So all our efforts became pointed at containing the pandemic, the epidemic, at least in Italy, when we talk about Italy.
I'm curious to know if there were, if, of course, in the moment during a pandemic, you're learning about executing infection prevention and control initiatives and how best to execute that. Can you share with us some of the implications or challenges that you faced with there not being possibly that widespread knowledge on, transmission-based precautions, for example?
Well, what I experienced is that right at that time, everybody was so scared about themselves. Like everybody was so focused about protecting him or herself from COVID-19 that the focus of protecting the patients from the spreading of MDR bacteria or other pathogens became disappeared completely, especially in the first part. Everybody was so scared, and we forgot about the importance of protecting your patient, especially with the contact precaution, for instance. So that was the main issue, especially in the first wave, I think.
Yes, it was an overwhelming, completely overwhelmed the hospital systems in certain cities here as well. So, with the increasing focus of globalization and, every new infectious threat, I guess, is really just a plane ride away. So how do you see the future of infection control evolving? Tatiana, we'll start with you.
Thank you, Kelly, for the great question. I think, and I really do hope that infection control, both from public and as well as hospital level, will become an essential and integral part of every healthcare system around the globe. Because as we do know, pathogens do not know the boundaries and they just spread wherever they go. So the effective communication and collaboration among individual countries around the world, as well as among counties within individual states, is and will be essential to stop the further spread of infections. So I really do wish for a strong workforce of skilled infectious disease specialists here in Slovakia, which we do lack right now, but also all around the world.
Yes, I could not agree more. And Filippo, what about you? Same question.
Thank you. Yeah, I do agree with Tatiana that the global communication is the core of it. If I must say, what I'm seeing as a useful tool in the next future are the rapid microbiological assessments, like for instance PCR deployment, especially for rapid swab. For MRSA, for instance, those are like the next big thing, at least for us here, in order to implement infection prevention and control strategies.
Oh, you make a very good point, because currently you're waiting, 5 days for a blood culture to come back? Yeah, it's a long time.
Yeah, exactly. Precisely. Especially on immunocompromised patients or critic patients, I really would like to have faster antibiograms, or at least a faster microbiology samples to come and help me out in putting some empirical therapy on those patients. That's pivotal in our setting, I think.
Yes, because you can make an educated guess on your antibiograms and then your gram stain, but the person could potentially have unnecessary antibiotics for 3 to 4 days until you get that pathogen and can really focus in the therapy. Yeah, you make a very great point.
So, of course, with the future outlook of our profession in infection prevention and control, there's always the questions of new technologies and or new ways for us to advance and bolster our efforts in IPC. So I'm curious to know, what are some things, some new technologies or approaches that the both of you are excited about? Tatiana, I'll start with you.
Yeah, that's a great question. I know there's a lot of great infection control AI tools and applications. Of course, you need to have financial resources. Some of them might be expensive. That was something I was struggling with in Slovakia. That lack of resources really puts you back in a different century. Sometimes almost it feels that way. But having a good AI tool to enhance more efficient and accurate HAI data collection, I think, is a big game changer for any infection preventionist. But I also specifically really enjoyed using this app that helped me to monitor and evaluate quality of environmental services in our hospital. And it was really a great tool. And it almost always correlated with AHI surveillance data. So in other words, whenever I saw there was a poor quality of cleaning of hospital services in a certain area of a hospital, I could always see it in a surveillance as well. So that was a really great tool, just one of the few that I've tried. But overall, what I really want to emphasize is that having any kind of technology or IPC tools really save the time and enable infection preventionists to spend more time out there to engage with healthcare workers and frontline staff and to create those strong, meaningful relationships that you really, really do need if you want people to follow along and, work with you and adhere to IPC protocols. So it's really important to be out there as much as possible. And all these technologies can really enable you to do that. So I'm excited about any kind of a technology that helps us to be more out there with our staff.
Absolutely, Tatiana, and that app definitely sounds interesting. So Filippo, same question to you. What are some new technologies or IPC approaches that you're excited about?
Thank you very much for the question. Actually, my most, as I said, the most proficient tool that we're implementing here for infection prevention and control are fast PCR swabs for anything really, both for carbapenem producing Enterobacterialis or for MRSA. And I think that that kind of technology is really changing the game for us. So I'm really excited about that. And for the future, I hope that we will understand better how to use artificial intelligence, because so far we are not really having great experiences with that, mostly because most of the practitioners are still they don't trust the artificial intelligence. But I think we should work on that and try to implement new ways on using them, especially, as Tatiana said, on the data ordering and the data viewing, because that's really a lot of work that could be done in a snap of fingers. So we should implement that, really.
Absolutely. Definitely. Of course, even here in the States, there's a lot of conversation related to the use of AI and the benefits of it. And of course, as in healthcare overall, it's ever changing, and the uses and benefits of AI and its impact on our profession would be of benefit. Do you foresee any potential strategies to overcome that, the concerns related to AI incorporation within your area, Filippo?
So far, I'm planning on giving a journal club on artificial intelligence to my trainees and my fellow colleagues, because I think that like learning and teaching it's the first step really about that. And I don't foresee any other implementation so far in my setting. I have no. I don't foresee anything. I cannot touch something right now, so I'm sorry about that.
Oh, no, we are in the early days of AI for sure. I think that, even in the next year, but certainly too, we'll see more and more integration of AI into things like our electronic medical records, your dictation, in different ways. So I think we do need to keep our toes dipped into the AI waters so that we can make sure that we are staying abreast of the newest developments. But Tatiana, I wanted to circle back around. What is the name of your app? What's the app that you were referring to?
Oh, it's called Encompass. I'm not quite sure if I'm pronouncing it the right way. It was provided by one of the companies from which we were purchasing our disinfectants. So it was like a little tool on a phone, and I was marking all these frequently touched surfaces with fluorescent gel, and then I would, within 24 hours, I would came back and just use a special torch to see if it was cleaned or not. And then I was entering all the information into this tool, into this app, and it was calculating the overall percentage of cleanliness of all of these high-touch surfaces by individual words. So it was just very helpful.
Oh, it is. And a great educational tool to share with staff. Yeah, as well.
Mm-hmm. Yeah. I would always take it back to environmental services manager, and we would go over individual words and look for the problems, like why this one is having such a low rate of good quality cleaning. And we could always come up with some good solutions, and it really worked. And it showed in my data surveillance as well.
Yeah, that's
amazing.
Wonderful.
Yeah, it's amazing. Well, Tatiana, Filippo, it's truly been a pleasure talking with you all and learning about the IPC programs within your respective areas in Slovakia and in Italy, and to advance our conversations related to global health IPC.
I echo what Lerenza said. It has been such a pleasure hearing your global perspectives. Also knowing that, we share a lot of the same challenges. So thank you for being here and sharing your expertise with us.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.